Two, one.
Perfect. Hey, everybody. I want to welcome you to another Facebook Live held by Community Education Group. Hey, Natalie. Thanks for joining us. One of the things that I want to be able to do is always have conversations that are hopefully interesting, number one. And number two, but that they are conversational, cross cutting, and that I have the opportunity. Yeah, that's right. You went right into a live, putting on your lipstick. You sure did.
Rise up.
But you did it for World AIDS Day and you got on red. Mute your background because there's a lot of noise in your background, Dr. McCants. Hit mute. All right, perfect. Appreciate. Oh no, that wasn't you. See, look, I got loud and wrong, and that's the good thing about these. So my name is A. Tony Young. I'm the founding executive director of Community Education Group, and today I wanted to have a conversation about HIV, and particularly around PrEP uptake and understanding and awareness and how we reach more women of color with a group of people. Some I can include friends, family, board members, federal officials, local folks, but I wanted to have a conversation with them, but also with you. So, for those of you who have tapped in, I hope that you'll ask questions. Ask the hard question of them and me and of us and all of that. So, first, I'm going to let folks go around and introduce themselves and what connection they have with either HIV, PrEP, or with women of color, or what they do. And so, I'm going to start with you, Miss Scott. I'm going to start with you first.
Okay, well, good morning. So glad to be here. Excited to share this space with you all this morning. I'm Sharice Scott, CEO and founder of Sister Reach, both here in Tennessee and in Chicago, Illinois. We are a reproductive and sexual justice organization working from a four-pronged strategy of education, policy and advocacy, culture change, and harm reduction. And for the last 13 years in Tennessee, we have been doing distributing contraception as well as doing comprehensive reproductive and sexual health education, which includes an emphasis on HIV with the target population of Black women and girls and young people overall of color. And we are the only Black-led organization in Memphis that offers free HIV testing in the city.
Oh, well, good. Congratulations on the work that you're doing and on your service to the community. I'm going to talk later about how I think Tennessee is a bellwether state that we keep missing and the reasons why I think that. And it's Dr. Patel, correct? It's Dr. Patel. Is it? Yes? All right.
Um,
Dr.
well, on
Patel.
this, we don't have to use form. I can
No,
go,
no, 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 no.
by Rupa.
You earned it, so we use it. That's the
But
way we roll around here, Dr. Patel.
so thanks for allowing me to join this wonderful conversation and group. My name is Rupa Patel, and I'm at the CDC. I've taken the role of the late Dawn Smith, so many of you have known her. So it's a privilege to transition into that position. And so you've known that position. Basically, I'm the clinical biomedical HIV prevention activity lead, and that means all clinical prep. So I help work on protocols, provider education, community education, the clinical prep guidelines. So it's a privilege to work with CDC and other federal partners and the community.
Perfect. Thank you so much. And Ms. Sanchez, are you the co-chair of Pacha now with Marlene McNeese?
Oh, no, I wish I had that honor, but no, I'm not. So I'm the co-chair of our PrEP and Stigma Disparities Group. And yes, I'm a Pacha member, a current Pacha member, and serving
tell people what Pacha is because people may not know.
Okay. Yes, I know. We get so carried away with saying Pacha. So Pacha is the Presidential Advisory Council on HIV/AIDS, and we report and advise the Secretary of Health on
Perfect.
HIV related topics.
Thank you so much. And then I have my dear friend and our board chair, shameless plug. Don't forget my paperwork for my raise is coming your way. Dr. McCants, would you like to introduce yourself to the good people?
With the excellent work that you have been doing, A. Tony Young, I would gladly sign that paperwork. I am honored to be here. I am Tamara McCants. I am a pharmacist and the current chair of the Board of Directors for Community Education Group and the president of the National Pharmaceutical Association.
All right, now I always think that title is a little funny. So can you tell the people what the National Pharmaceutical Association is?
Yep. So the National Pharmaceutical Association is the only national pharmacy organization dedicated to represent the views of minority pharmacists, pharmacy students, and pharmacy technicians, with the overall goal to ensure that we are addressing the health disparities of our most vulnerable communities. And so the word national comes at a time when it was a secret code word when people of color weren't allowed to join the regular American XYZ organization. National was code for the organization for Blacks.
So and so you because you spoke in code, and so everybody's not as smart as you. So what you were trying to really say is that there was a time when Black folk and people of color couldn't join the AMA and the other larger medical and other types of associations. So folks started their own and used national instead of American or whatever as the lead. Is that correct?
Yep, that's exactly right.
Perfect. Thank you. They pay me good, as you can attest. And so I'd like to introduce my good friend Judith. Judith, you want to tell the good people what you do for a living?
Well, good morning. My name is Judith Montenegro. I'm the program director of Latinos in the South. It's a regional program out of 9 states from North Carolina to Texas by the Latino Commission on AIDS.
Perfect. Thank you. And last but definitely not least, Marlene McNeese. And you are actually, I know, the co-chair of PACHA, as well as you work in the is it Harris County Department of Health. Is that correct? Do I have that right?
The City of Houston Department of Health.
Okay, sorry. My fault. Again, corrected. But go ahead. Tell the good people what you do.
So, hello everyone, and again, I work primarily overseeing our HIV, STI, and hepatitis prevention programs at the City of Houston Health Department. And essentially, we work in partnership with the community to implement evidence-based interventions that are targeted toward those infections and those diseases. So lots of community partners that help us with HIV prevention, lots of community partners that help us get the word out about what we need to do around hepatitis and other syndemic approaches. So just the implementers in partnership with many of our community organizations here in Houston.
Wait a minute. You know, we can't be using big words because because I'm on here and I'm not that smart. So you said a syndemic approach. What was that? That's what we do here. But how do you mean it?
And, essentially, a lot of us in this work have been doing syndemic approaches for a long time, meaning we are working to ensure that the impact of multiple epidemics, HIV could be considered an epidemic. Sexually transmitted infections, especially like syphilis, is its own epidemic. So we work in tandem when we address multiple infections, multiple epidemics at the same time to achieve a greater health impact and health result. What we know is many people in our community are impacted by multiple issues around health inequity. And so what we try to do with syndemic approaches, addressing more than one epidemic at a time, we're really trying to bring more holistic health services to individuals. So when we say syndemic, we mean it in a practical way, that we're not just talking about one issue, one disease state at a time, that we're really trying to work holistically with an individual to talk about all of the health needs that individual person may have. So thank you for having me clarify.
All right, I'm not new to this. I'm true to this. So here's the thing that I also want to talk about today, and Dr. Patel, I want to talk a bit about it. I'm going to start with you, and I'm not picking on you, but I want to start with you. Is that one of the things that I feel like we don't do well, or as well as we could, is actually using digital platforms and social media influencers in particular to reach young women of color about HIV, but most importantly about PrEP uptake and where we are. Now I'm gonna give a little bit of a what I think is the case. I think that particularly for many young women, we kind of give them a false narrative about them not being a part of our solution in the HIV epidemic, whether we are talking about it from a PrEP framework or whether we're talking about it from a treatment prep a framework, a testing framework. We seem to leave them out a lot. Can you talk to me about kind of maybe what the CDC is doing, what your office is doing, especially around educating women of color, young women of color about PrEP and on digital platforms?
Yeah, thank you. That's a great point in where we're missing the mark in general over the last couple of years, even the last decade on messaging. So one of the things solution based is we're doing campaigns related to PrEP, and some of the hallmarks of those campaigns, which go into what some of the literature shows and what the community has been saying is, first, one of the gaps has been trusted messengers, community influencers, friends telling friends, like a peer-to-peer approach. And part of that messaging has to start from the very beginning. It's great to talk about PrEP, but you've got to take 5 steps back and just talk about sexual health, like the empowerment to say, I have a partner. Can I ask my partner what their HIV status? Do I want to know my status? Like, is there all this stigma about this discussion? And that's actually what is the problem. We go straight to PrEP. We're so fixated on PrEP number and the outcomes and the uptake numbers and acceptability and willingness to use. But we need trusted messengers, which we're doing in the campaigns. We need to break down the misconceptions about PrEP. Some of the, oh my gosh, this is a medication, it's bad for me, there's not been enough studies, etc. And then the messaging around, we see these messages, but a lot of people process, this isn't for me. I'm not in this category. I'm not at risk. It's about risk perception. But it goes all back to like, what's the conversation? And can I have the conversation? And should I be a part of this conversation? Because you're correct. It's been so hyper focused about potentially gay men or people who use needles or, certain persons that have certain lifestyles. But we got to take a step back and normalize the conversation. It's a conversation about well-being, and it fits in the syndemics. We need to talk about it with routine primary care instead of hyper focusing it at some type of HIV testing event only, where people don't want to even go near that billboard. So we're doing a lot of campaigns around those concepts. And I think we lost Tony.
We did. I wanted to see, while we wait for Tony, if I could just add, talking about using influencers. We partnered with Ashley Cobb. I believe she's from Atlanta, but she's an influencer with a following, and she's, talks about sexual health. She talks about sex and pleasure. Again, I think as healthcare industry providers, we leave out the conversation of pleasure. And so we had the opportunity to partner with her to come on our Confessions podcast. And so she was our first woman who was not HIV positive to talk about her experience of being a Black woman who is utilizing PrEP and utilizing her platform to talk about how everybody is HIV possible, not just men, not just certain people, but everybody is HIV possible if they're not HIV positive. And I felt that that was a great collaboration for us as a healthcare institution and getting information to the community about PrEP in women.
I really like that, HIV possible. I mean, because I think it's Ray Lewis Thornton, and many of you may know her. She was the first person, but first woman, Black woman, on the cover of Essence magazine. And gosh, that had to be more than 20 years ago, living with HIV. And one of the things that Ray would always say, heterosexually identified Black woman in Chicago, and she would always say, if the penis isn't in your pocket, you don't know where it's been. So you need to take all of those sorts of precautions for that. And so, and maybe I'm equally as guilty of kind of putting PrEP in the front and not saying we need to have more conversation. Because I always say we don't see advertising for HIV care and treatment at like beach parties for the Virginia Beach weekend and all of that. We don't see that kind of advertising out there and that outreach out there. Dr. McCants, I know that you do work both with the pharmaceutical association, but also with a group of pharmacists. But I also know that you do a bunch of like community engagement opportunities. What do you see out there?
So, I was really just sitting here trying to think about, exactly how I'm going to say this and what I'm going to say, but I'm here for a short time, so I'm going to have a good time while I'm here. First of all, I think that the election showed us that we can't always depend on influencers to give people the message. I think we overutilize influencers when we're trying to get to people of color. And we underestimate that people want factual from the people that know the information, which in this example are healthcare professionals. And so, yes, I am going to be biased and talk about the fact that the pharmacist is and continues to be the most accessible healthcare professional in the country. And so when you have pharmacists that are engaged, when you have your medical assistant that's engaged while you're taking the person's vital signs, when you have the person that is what we like to call the low-level practitioners that have the most influence and the most conversations with our patients in a short, non-biased period of time, that's when we need to be assessing the risk. It needs to be like a regular vital sign. I think we keep on trying to figure out these grandiose schemes about on the billboards and let's have Tupac come back from the dead and women to get on PrEP, but that's not. I think we really need to oversimplify it. We really need to have regular conversations with people on a regular basis, and in our own communities, those of us that are healthcare professionals and that's in this space, we got to have conversation with our own families. My sorority sisters, we have to normalize that we are all unprotected sex. You are at risk. Period. And so we don't talk about it enough on a regular basis.
Well, I mean, I'm going to talk about that in a minute, about the role that I feel like Black men play in this conversation, who I think have been left out of this conversation. And when I say Black men, I'm talking about Black men who identify and are heterosexually identified. They exist. And, we seem to think that they're unicorns. And I don't think that they are. And I think that there's a dynamic here where we just don't talk. Not only do we not talk to them, we don't talk about them. And whether those are Black men or particularly men of color who identify. I see you shaking your head, Ms. Scott. So tell me, what are you seeing in your kind of community of practice?
We're really not putting enough information out where I live in Memphis. I think that, we just have to be very honest about who the target has been for years. And we've just not done a great job of making sure that we are centering Black women and girls, folks who are not part of our LGBTQ community, and even more specifically, Black men who sleep with men and trans identified individuals. That we're missing so many other people in this conversation because we have not, because of whatever the statistics didn't say or the research wasn't done, right? So for us at Sister Reach, we have intentionally been centering Black women, and not just any Black woman, but Black women and girls who may or may not necessarily come from a quote unquote marginalized economic population, right? Everybody Black isn't poor. And so I think that we in the reproductive justice world have not done a really great job of reaching folks who are affluent, working class, senior professionals. And so a lot of our work is we're trying to do an even balance of that and trying to do that even more intentionally. So working with influencers now, I just had a whole overview done of marketing review of what we have been doing over the last 3 years from folks that we trust here in the city who, who have their finger on the pulse of what's happening around branding and social media engagement. And, our stuff has just been a little bit more flat, more flyers, more infographics, and they're not resonating as much with our populations. But what we are trying to do is, how do we use TikTok? How do we use LinkedIn? How do we use, these other ways of getting to folks? How we use video? How do we do a quick reel, and just make our content a bit more interactive and engaging, even doing a website rehaul just to make it look better, right? Even if it's the same information, repackaging that information to make it be appealing, adding a blog, adding opportunities for folks to engage in the ways that they're already working, in the kind of internet space on social, just kind of meeting that moment. So we were a little bit behind, I think. We were putting out pretty graphics, but they weren't doing anything, right? It's only so many times you put a flyer out that folks are like, okay, and the engagement just goes down. So we really, so that's the kind of the digital way. But digital also thinking about like geo tracking is something that we've used in the past with some other work that I've been a part of, coalition based, where we're able to like hover over zip codes so that when you're on your phone, stuff comes up in your phone. We've done that with young people around making sure that young people had access to sexual health education, resources, and doctors in the city. So we're thinking about how we utilize some of those same tools and skills for how we get the word out better about PrEP, about HIV. I'm going to go with what Ms. Patel said. We're just not doing a really good job talking about sex. We're not talking about, we're not talking about sexual health anymore. And I think one of the things for us is, a lot of folks in our movement tend to have put so much focus on abortion that we weren't talking about, sexual safety, and really thinking about ways that we can get STI numbers down beyond just thinking about HIV, how we can focus on things other than pregnancy, right? And just think about people's holistic health, wellness, and behavior trends, focusing on that, trying to figure out how we do a better job of speaking to some of that as well.
Perfect. Thank you so much. Judith, what are y'all doing any digital work? You doing any influencer work?
So we launched a campaign with the Southern AIDS Coalition and the North Carolina AIDS Action Network last year called A and Her. And it was really a conversation for more Black and Latina women to talk about PrEP, but also PEP. I think it is an underutilized prevention method. It makes a lot of sense to a lot of people that there is a pill that looks like the day after pill, right? And a pill that many women could resonate with. And so Gilead doesn't even track how many prescriptions happen for PEP. And so this is one thing in North Carolina where we have pharmacists who can prescribe post-exposure prophylaxis. We also have pharmacists who can prescribe birth control. And so it's a really great opportunity, I think, and I agree with the folks here that pharmacists have a role to play here, especially in rural communities around women. But I also think that the conversation around PrEP is often one that wants to be sexy. And I don't think PrEP and PEP have to be sexy, right? Like, I think it's just about getting information out. A lot of times when we did the focus groups, especially with promotoras or community health workers, with women around these initiatives and around our campaign, a lot of them shared that it was really difficult for women to come to terms that maybe they were not in monogamous relationships like they thought, right? And so how do you get past that barrier? It's not necessarily a barrier of information, but rather a culture shift that women, we are responsible for our own health care, and that messaging that this is about your health, it's about wellness. It's not necessarily about admitting anything romantically, right? It's just about another preventative measure.
Thanks. And Miss McNeese, the Pacha doing a social media campaign? And that would be through HIV.gov though, right?
So, PACHA, as an advisory council, really our work, the mission that we are charged to do is providing advice and recommendations to the Secretary of Health through the Assistant Secretary. So, yes, the work at HHS is usually informed by the community voices that they hear, including those of us who sit around the Pacha table and make advice and recommendation. But I would say, from an HHS point of view, I think the HIV.gov has been a platform, a successful platform, in which they've been able to get out information to the general public and the general population about the work that's going on in the government response with HIV.
All right. So, one of the things that we kind of like hit on and then we pinged off of it, but I want to talk about it, I want to come back to it, is really the role or the importance what I think has been an ignoring of men who identify as heterosexual and very well may be heterosexual as far as I know. But I think that we do this thing where we say, for example, that if a man is in the HIV space, that man has to either be on quote unquote the DL, or that man has to he's sniffing around because he's got to be having sex with men somewhere. He wouldn't be wanting to have this conversation otherwise. Now, that causes a problem, I think, or causes a challenge, not just in communities of color. I mean, I'm out in Appalachia, so I've got, folks who are like, hey, we've got these high rates, particularly around hepatitis C, and in some clusters, HIV. But those individuals, when they go to look at an ad, they don't see themselves. When they go to look at a testing algorithm, they say, not me. And I'm like, yeah, no, we're talking to you because of other behavior, right? Other things that are in your social, sexual, drug sharing, familial, and communal network. So, can you talk to me a bit about how we can do a better job of bringing individuals, both men and women, I think, and we talk about it from a male perspective because I think it's an important missing link. How do we talk to them better about everything from testing for HIV to how do they accessing care and treatment to, I mean, if we want to talk about the prep part, we can, but I think really a big part of it is about having this conversation about just them in a part of a social, sexual, sharing familial network. How do we do it? Why haven't
So
we done it?
yeah, I think we have done it. I think with routine HIV testing, routine STI screening, when it's done right, does reach everybody and is inclusive of the heterosexual community. And in California, doing routine HIV testing, we're able to diagnose people who don't necessarily have the high risk factors. And I think we have so long focused on high risk factors and certain target populations that, again, in routine testing, when you're testing everybody, you're testing people not even having to ask about the sexual health history, not talking about number of partners, but we're able to identify heterosexual men, heterosexual women, other individuals who are at risk. The other population that's at risk and has had an increase in new HIV infections are women over the age of 55. So, even in talking about this conversation, I think sometimes we go to the younger population of women when in reality, the women that are affected are 25 years and older,
Mm.
and so really being inclusive of all age groups of women. But just talking about a great way to reach heterosexual men, I think routine HIV and STI screening is a great way of reaching those individuals.
Well, stop there for a second. So, do we think that folks are not having this conversation with older adults, period, women and men, because everybody thinks that they're not having sex? But if you look at the rate of STIs that are happening, particularly in senior living facilities, I think we see a different story if we look at the data. And I'm going to go, and I know Dr. Patel's like, I didn't sign up for that question, but I'm getting.
No, I was just wanting to jump in. So thank you. No, I was just thinking, this has to be a multi-generational approach. And we've really got to reach young men while, they're developing and they're like through their process of growth, they're thinking, okay, it's okay to talk about sex. And I was just thinking of the situation where in many communities of color and cultural communities, the woman bears the burden to bring up the conversation. And if she did, she's, she's been sleeping around and she's been dirty. Like, it's the stigma again that goes, who's bringing up the conversation first? And the dream is to have more equality in that conversation. Like, both people were thinking about it and brought it up together, or someone's not always bringing it up and then having to defend themselves for bringing up the notion of let's get testing or let's just talk about STIs. And so it's also thinking about who are the knowledge brokers and the influencers of young men. These are still grandmothers, aunts that they're living in houses in, their mothers, it's the barbershops, it's the churches, it's still your entire community. It's the pharmacists, it's everything that you're touching every day. It's social media, it's friends. So I think we can't have a siloed approach, but again, it's multi-generational, it's diffuse, again, to normalize that conversation of, oh, we're talking about this. Like, we're talking about, you got to wear a seatbelt, a motorcycle helmet, helmet with your bike. You got to talk about food security, but also well-being is your diabetes check, and also what's happening with, STIs, and are you at risk? And decoupling, just using the word HIV is not okay anymore. There's so many other things, like we said, hepatitis. It's the syndemic approach, and that's going to strengthen the conversation as well if we fold it into everything, communicable diseases.
So I want to say something real quick. Like, I think that what we're doing is, because women are always problem solvers, is we're making the classic mistake we always make, asking a bunch of women, how should we communicate with men? And we do that all the time, right? Like, if we want to know how to get with our dudes, we need to ask the dudes. Like, we need to ask them, what type of messaging is for them. And even as it relates to the older population, which is why I'm actually streaming from Facebook, because, Facebook is the old people. We don't do a lot of stuff to the to that demographic. I see everybody laughing, but everybody acting like they don't have Facebook. I still love Facebook. But my point is, especially for that population that you mentioned, that 55 and older, when you even think of the first two.
Uh-oh. Did she freeze or did I again? She
did.
froze. She froze. All right.
Yeah.
It's that Facebook connection.
Is that your Facebook connection froze?
Oh, but I just wanted to say one more thing about PEP. Whoever said PEP, I really think that is the key to it, because if you think of PEP just like.
Uh-oh. All right. Well, we'll let her come back in when she unfreezes over on Facebook. But I can't even lie, because I don't even know how I froze. But so here's one of the things that I want to talk about, is that I think a lot of people don't know what or where we are in our response to HIV. Many people believe that HIV is over. And, for those that, maybe I skipped over it, kind of like why we're even having these conversations today. But yesterday was World AIDS Day. And so that was the impetus for this conversation, other than I like talking to all of y'all, because, me, I just like talking. But I wanted to say that I think that many people in the country, particularly the average person, is not immersed in public health or not immersed in HIV, doesn't know where we are, right? They don't know that you can take medication and be a person living with HIV and be undetectable. They don't know that you can take medication to prevent you from contracting HIV if you're HIV negative. And so what I want to talk a bit about, and maybe we can kind of go around and talk about what's where we are with HIV, because I believe I have a couple of core beliefs. One is that of the roughly 20% of HIV cases that we say we can't find in this country, and then the other, like roughly 40% of hepatitis C cases we say we can't find. I think that they're sitting in medically assisted treatment clinics. That's buprenorphine, Suboxone, methadone, and that we are not doing consistent testing and linking to care from there. I think that that's part of it. I think the other part of it is that we still think of it as a gay disease and an urban disease. And I think we've got to figure out what we're going to have in a suburban and rural conversation and dialogue. So, can you guys talk about women? Talk about kind of what the top three things are that you see of where we are. Like, okay, here's the treatment stuff, and the kind of what we need to do and where people need to go. And the reason I really want to bring this up is because of we have to have this conversation honestly about where we are with treatment. We've got, because what you got Cabenuva, which is a V product 4 times a year. You got Gilead coming out with a product, lenacapavir, twice a year. So these are really paradigm shifters. But at some point, I got to believe that someone's going to say, hey, wait a minute. There's this thing to prevent it, and there's this thing to treat it. So those of you who fall in the middle, I don't know what to tell you. So, I mean, where are we going to go, and how do we begin to educate the people that need it? That 25%, that 25%, 20% with HIV, they're living with HIV, but then the other group that is probably impacted by hepatitis C. And let's not forget what they say is that syphilis screening is the predictor for PrEP uptake. Like if you have a syphilis screen, you're more likely to be willing to take PrEP. So that was a whole bunch of hyperbole. And now I'm going to let you guys tell me what you heard and what I just said.
Tony, can I jump in, because you stole some of the words right out of my mouth, because I wanted to talk about the pipeline. So today we've got PrEP, and let's not forget DoxyPEP.
Dr. P, what's Dr. P? What's DoxyPEP? Right.
So DoxyPEP is a medication that has not been shown in women yet, but I'm optimistic we'll have more studies around it, and that's why I'm just talking about it, because it's still part of the prevention discussion. And we do engage with men and partners of women. And so it's just something to talk about. It does protect our women. And so it is a medication where you can use doxycycline to take within 72 hours of if there was an exposure. And it's been cutting the rates of gonorrhea, chlamydia, and syphilis by substantial amounts. And I'm optimistic that there'll be more studies in women where we'll see that it'll work with women. And I bring that up because the iconic study in women was done in Africa. And part of the complexities with that study was people didn't take the medication because they didn't really, they thought it was an experiment. It hadn't been proven yet. And that happens to us a lot in medicine. But not to divert from that, we have very interesting technology today. I want to brush upon lenacapavir is a medication that goes into your stomach like an insulin shot. It's every 6 months. And then with that, that's also used for treatment, but it's used for drug-resistant treatment. But there are more studies to bring that out in the mainstream, because it's a very nice product in the sense of it's every 6 months. And then we have cabotegravir and rilpivirine, which we call Cabenuva. That's cabotegravir is every 2 months for treatment, for prevention, and also every 2 months for treatment when you put it with rilpivirine. Why I'm bringing this up is we have this concept of longer acting medications that are not daily oral pills that really can help us if they're delivered, in an optimistic way, in the ideal way. So for the clinics today that have used cabotegravir and rilpivirine or Cabenuva, we have seen suppression rates for HIV that you couldn't think of. We are seeing now clinics actually bring it out into homes where they're reaching people that they couldn't with daily oral medication. So I just want to let you, there has been technology, and that technology has been shown to bring us closer to suppression rates that you didn't see since the 1980s. And there are certain cities in the world, in the US, San Francisco is one of them, Australia, countries in Europe, where they showed where they could get PrEP everywhere because their healthcare delivery system was different than potentially ours. They have a centralized system. Plus, you had treatment as prevention. Don't forget, that's part of our World's AIDS Day discussion of U equals U. When you couple treatment as prevention, that means you were able to give people medication that had the HIV infection. They went ahead and suppressed their virus for over 6 months. U equals U is you suppress the virus 3 to 6 months. And you show that when you have suppressed virus, it's very difficult to go ahead and transfer. So when you had U equals U as a public health approach with PrEP, you had the lowest rates of new infections since the 1980s. These are game changers and have been shown to work on a population and country level. So I wanted to highlight the technologies there today. I also want to bring to your attention, we have FDA approved products such as cabotegravir that's being looked at as every 6 months.
Okay.
Optimistic, there's things coming out in the pipeline. In fact, we're talking about a biodegradable 1-year implant in the future. We're talking about 1-month oral pill in the future. So we're talking about really easy technology, possibly to go door to door through community health workers. So I wanted to let you know, technology is coming down there. Where are the gaps? The gaps are we're not really reaching. We have to take it upon ourselves as a healthcare system and community healthcare approach. We need to reach people. It is inappropriate to ask people to come to clinic. I think we all agree on that. And so I'm hoping and I'm optimistic that we can get these new technologies out to where people need to be. So street medicine, pharmacy, pharmacist based things. I think the dream when I was in St. Louis and interviewing young Black men, they're like, Doc, we want to be able to go get our chewing gum or soda and then be able to get our HIV test and get our PrEP if we want to. Like, we don't want to like tell people we have to go to a clinic. So it's again this concept of differentiated service delivery. Can you get it at mobile vans, homes, group homes, street medicine, bathhouses, like wherever you want to go, salons, wherever women want to go, wherever men want to go. It's, to me, it's the general conversation of like just getting healthcare out of the clinic. And to do that, also, we need policies to do that. Can a doctor give an injection on a street? Can I do that in every state? Can I do that federally? Those are conversations we're having. I also am a practitioner at Whitman Walker. So we're having these conversations at Whitman Walker Health of like, where can we give lenacapavir in the future? Mm-hmm. It's like it's an insulin injection. That's a dream. Not a big injection, not a large volume injection like you have with some of the other things. So we need to be thinking about that as a community of like, who can deliver what, where, so we can optimize the technology. And I think our healthcare system, I want to bring in the elephant in the room, getting access to some of the injectables has been a situation, cost, insurance. So those are some of the things we need to talk about. Sorry, I didn't mean to hog the mic.
No. This is what the conversation is, right? And I think this is what the conversation needs to be. I think sometimes what we don't do is stop and have the conversation, because I think what I was going to say is that the other piece of this builds on is some of the work that we've been doing and of trying to make sure or ensure that community health workers are reimbursable all across the United States, because it's different in every state. And we believe that there should be a standardized reimbursement policy to utilize community health workers to do a lot of this work. I mean, in the District of Columbia, CEG was testing over 10,000 people a year. That was an HIV test, a Hep C test. Can you then train that individual to be a phlebotomist? Can a phlebotomist then deliver this treatment? I think that depending on whether or not they are CLIA waived and all of that is a reasonable consideration. But I think that this is something that we have to think about, is that the people that we're trying to reach, again, that was in DC. We now are about to deploy over 200 community health workers throughout Appalachia, and we have an event that we're doing in September where our plan is to test 2,500 people over a 3-day window. We should be able to offer those folks treatment on demand. And I think that that's one of the things that we don't know about as much. So what I'm going to do is I'm actually going to pick on Marlene and on Natalie. And here's why. Is because we are supposed to be ending the epidemic, right? And we started out with what I think it was like 58 jurisdictions or something like that. You're going to tell me what the number is or whatever it was. And so when we look at how we're going to end the epidemic, I think Dr. Patel just mapped it out for us, right? Is that what we've got to do is that we have to test, treat our way out of this. We don't get to just sit back and wait and think that folks are going to walk into our clinics. That, Marlene, that's where you say, yeah, right, you're right, Tony, and you're such a genius. I can't believe that you asked that question right here and right now. And oh my God, you are so smart. This is where I was looking for a little something like that, but since that didn't come, I guess I got to leave the witness.
You're brilliant, Tony. We're all brilliant. We're all the smartest people I've ever known, ever. I hope that's helpful. That's helpful.
It's all I
So,
needed today.
yeah. But I just wanted to echo. I think we touched on it in many ways on the call so far. But the elephant in the room for me, as you described and Dr. Patel prescribed, where are we? What has been our response for 40 years to HIV in this country, and where are we now, and where are we going? The issue for me is access. You said it before when you talked about the needs there in Appalachia. I sit in Texas, so it look a little different in terms of how we have to mobilize resources, information, response, approaches, etc. It looks a little different depending on our community, depending upon the resources we have, and carrying the right messages to the right people at the right time in the right settings. So for me, this access issue, because I sit in Texas where we are the highest or live with the highest rate of uninsured persons in the country, have been there for many years in a row. The idea that people can't get to a medical provider, clinical provider. I love the conversation about health workers, pharmacists, etc., but how we need to expand the use of our workforce in general to have deeper tentacles into communities who need this information most. It will likely not be in front of a medical provider, unfortunately, for many parts of folks who sit in Texas. So, what are some other alternatives? And making sure that all these wonderful advances in science and medicine. These have been fabulous, and maybe some of the reason why it's led to a little bit of apathy. But what we need to make sure for Black and Brown people is to know, yeah, these tools and advances have been made, but unfortunately, many of them have never heard of them. They don't have access to them. And certainly the idea that this becomes yet another thing to put on my plate to do, it all feels a bit overwhelming at times when we talk about some of the approaches and the tools. When you speak to lay people who are not involved in the work, it's overwhelming sometimes. So what we try to do, at least our approach here in Texas, is really approaching conversations with individuals about their entire health. What are their priorities? What are they most interested in? Once they have the information, they are typically the best leaders of the choices that they need to make to improve their health outcome. Not us, not me. So the idea that if I give you all the information, options, and tools, that I understand and hear your priorities so I can start matching what I know in terms of resources and availability and things like that, then we can better sort of create an ideal plan and planned approach for what is going to work for you, and not just work for you in the moment, but work for you across your lifespan of goals. When my goals in my 20s are not the same as my goals in my 50s. And so working with my healthcare provider about what are my healthcare goals, what are my overall life goals, and how can some of this work, some of these tools assist me in achieving that. So unfortunately, I think we've come a long way in making advances, and I'm glad that we have, and we've invested the money to get us here. But now the idea is to make sure that group of folk who are being left behind, they are not achieving viral suppression rates. They are not achieving holistic protection against many of these infections that we're talking about. They can, because the tools are out there, but how do we bridge the gap and make those connections for them? And I think it looks very unique and distinct depending upon where you live, depending upon what resources you may or may not have access to. The approach is unique and needs to be unique and different.
Yeah.
Perfect.
So I sit on the stigma and disparities work group of PACHA, and as Marlene said, is our work group is really much charged with looking at the health disparities and racial disparities in different communities, in different regions, the rural versus the urban. And the other key part of it is the stigma piece. And for us in our stigma and disparities work group is also acknowledging that what makes HIV unique is the stigma aspect, right? And so we can have, access, we can have access to free HIV testing, to treatment. But if there is that stigma associated with HIV, that's a big barrier for some individuals, some communities in accessing these things. The other thing that comes out for us in Pacha and some of the areas that we visit, and even just looking at the data, is that states that do not have Medicaid expansion have worse health outcomes than the states who do have that. So for us, that's a big policy piece of we want to make sure that there's Medicaid expansion in all areas if possible, and continuing to advocate for that because being able to have access to have health insurance is what's going to give you access to whether it's prevention tools or treatment tools. And then the other thing that lastly I wanted to share about our stigma and disparities work group is that for us is also we're having a large conversation about PrEP, and we kind of keep these PrEP conversations within our community. So we're looking at partnering with HIV.gov for a PrEP awareness day, so that we're not just promoting, World AIDS Day, HIV testing day, but we're also doing general information and education about PrEP, in all communities, using social media, using the media, and making sure that this information is getting into all communities.
Judith, what are you seeing in your communities in the South about around access?
So there's a few things that limit access in the communities that we work with. One is transportation. A lot of the communities that we work with are in rural settings. And so, especially in the Southeast, right? And so being able to identify providers that one are culturally responsive, right, to Latinx communities, and second, that have the infrastructure, which includes bilingual personnel, staff, to help translate some of these messaging. Aside from the language and transportation piece, part of the access issues is that we also work with a lot of folks who are undocumented and are fearful for accessing healthcare services, going to health departments because of so much xenophobic rhetoric that happens in the Southeast and now federally, right? Like we see more attacks on immigrants, um, on Haitians, right? And so these conversations, whenever we see these stigmatizing conversations, as Natalie mentioned, being reinforced systemically, institutionally, we also see a drop in care, and we're going to continue to see that into the new year, right? We'll see more folks limiting the types of services that they access because we've seen it before, right? Like we've been down this road already. And so it's going to take a lot of counter messaging from institutions, from health departments, from different providers to say that folks, it's safe to come here. Here's what your rights are. right? We see it in Texas also, where hospitals are now having to provide information as to whether folks have health insurance and are undocumented. And so this does create these barriers to care. And I know that it's just going to get harder. And so, as we think about ending the HIV epidemic, we continuously leave people out of conversations, out of funding, because there are communities who are invisibilized, in one part by choice, right? Like folks don't want to be seen, but on the other part, it's a response to what is happening institutionally and systemically to marginalized communities.
So, all right, Ms. Scott, what are you seeing down in Tennessee?
A lot of things are happening down here. I think we can't ignore the role of Christian nationalism in all of this. Okay. I'm in the Bible Belt. I'm in the buckle of the Bible Belt, a place where not only has Medicaid expansion been rejected, but HIV funding has also been rejected, not because of public health information, but because of misguided, misinformed, poor theology, poor rhetoric, shame and stigmatization that comes out of various churches, not even just the Black church, Black Christian church. So I think that we've got to really think about how to tackle lifting up opportunities, or thinking about our opportunities for more advocacy and education, even on a very baseline religious level, because that's a space that people trust. Where I live, that even goes, made me think about even the relationship dynamic between men and women, cisgendered, heterosexual folk, and what that looks like in marriage counseling and singles ministries. Like, how do we get more churches involved into this conversation? How do we create more opportunities? Like, Sister Reach is a place where people could come and be tested for free, but it surely would be dope if my church could offer the same thing, you know what I mean, where folks could get tested at church, would be so amazing. So I think that there is a lot of, I'm thinking more of kind of on the organizing level, the access level of like where we do our work and how we do our work. There are more folks who are looking into trying to provide more mobile based care. And I think some of the issues that we've even dealt with is, we had to change insurance providers, somebody who would allow us to actually test on our RV as opposed to not being allowed to test on our RV. So just like so many different things are kind of at play, not to mention like legislation that, was proposed over the last couple of years to try to stop mobile clinics, to try to stop folks from being able to reach people through those types of ways, right? So I think that we're going to have to deal with that piece right there, and the responsibility that the greater religious community has, and what it has contributed to why people think about HIV in one particular way with one particular group, and that group is supposedly, deserving of this outcome, rather than having real conversations about sexual health education and opportunities like that within a church setting. So that's some of the things that we do intentionally, because we are not allowed to go into the school system anymore, because we have advocated for abortion, because we have advocated for queer folk. We're not allowed in the school system in Tennessee anymore. So we have to figure out ways to get our message out, and utilizing clergy and laity and influential clergy. I'm gonna say that, right, who are progressive, who are constantly talking about issues that are impacting our communities beyond public health, but other issues as well, has been really helpful. Working with seminarians, getting in there before there's even folks, before we even think about pastors, how do we influence laity? How do we talk to first ladies, those types of things. So like a lot of our work is intentionally that way, because we recognize that we are combating a rhetoric that is anti-people, anti-health, anti-abundance, anti-wellness, anti-holistic health outcomes, and it's all being done in Jesus' name, and we need to start calling that out. That's not okay, right? So that's something that we do.
Well, thanks. And I'm gonna kind of come back around full circle. Where we began is where we're gonna end. Dr. McCants, what's the role that pharmacists can actually play in kind of knocking down some of these bricks to access.
Mm-hmm. Well, first of all, Tony, thank you so much for hosting this hour today because I have learned so much already. And part of what the National Pharmaceutical Association is doing is we are mobilizing our pharmacists. We are giving them the ability to know one, you are the answer to this, and you can make a difference in this. And you have the capacity, you have the education, you have the access to the people to be the answer. And so we understand that this comes down to the individual. Yes, we're the most accessible pharmacist, accessible healthcare professional, but if we don't feel like we can do it because we're overwhelmed or whatever the case may be, then we're not going to do it. And I think that we represent a microcosm of people in general. Like, gone are the days where we could just depend on the government to give this overall approach and give us a whole bunch of money to do it. It's by individual people, us hyping each other up, for lack of a better term, and encouraging each other internally that have the answers to be able to have a more outwardly approach.
Perfect. First of all, I want to thank you all for taking time out of what I know are extremely busy schedules, to give us an hour to have this conversation. And like I said earlier, I know none of us on this call are new to this. We're all true to this, and I really want to say that I think that we have a chance. We really do have a chance to knock HIV in the mouth. But it is going to take each one of us in our own individual communities doing that. And want to make sure that we also speak to the importance of bringing in our behavioral health partners to this and our MAP provider partners to this, because I think we've done a disservice to many communities by not making them a strong entry point for us in this work. And so I hope that as you go on, for those of you that are watching this and that will maybe watch this later, either in full or in some piece, understand that MAP providers, community health departments, federally qualified health centers, and all of us have a role to play in ending HIV. We've got the technology, we've got the science, but it really, as I think everybody just said in this last round, it's going to take us to do the job. And it takes you to be a participant to do the job. Thank you, everybody. Thank you for everything that you do. And thank you for having the time to take and chat with the people. We can get you a copy of this, and we can make sure that you're able to cut it up any way that you want to. Make sure you center me, though, because.
Thank you, Tony. Thank you all so much. I'm
Thanks,
so
everybody.
Thank
honored to be
you.
on this panel.
Thank you.
Thank you.